Good evening. Today we will be presenting antisocial personality disorder with Janacy Gonzalez, Cynthia Milian, and Damali Scipio. Our case presents Mr. Alexander or Alex Jensen, an 18-year-old single heterosexual Caucasian male undergoing a court-ordered forensic evaluation after convictions for large-scale cryptocurrency fraud and an aggravated assault incident. Alex's childhood was marked by parental alcoholism, inconsistent discipline, and chronic exposure to violence, conditions strongly associated with later antisocial personality disorder. By 14, he had a formal conduct disorder diagnosis following persistent truancy, theft, and fighting. As an adolescent, he finances a lavish lifestyle through sophisticated identity theft rings, employing multiple online aliases and advanced social engineering tactics. During interviews, he is superficially charming and articulate, yet reacts with explosive rage when criticized or denied his demands. Alex has always shown a disregard for others' feelings. He's had difficulty with impulsiveness throughout his entire life and is always looking for personal gain without having an empathy towards others. When asked what he is thinking, he states, "I have difficulty being around officers and law enforcement." He disdains legitimate employment, ignores debts, and rationalizes criminal activity as smart business. Noting his manipulative courtroom demeanor and complete absence of remorse towards victims, the sentencing judge has requested a focused psychiatric assessment to confirm ASPD and guide risk management and rehabilitation planning. Alex displays the full DSM-5-TR constellation of antisocial personality disorder: persistent unlawful conduct, pathological deceit, impulsivity, aggressiveness, chronic irresponsibility, and lack of remorse, all beginning before age 15 and continuing into adulthood. In community samples, antisocial personality disorder affects roughly 1 to 4% of adults. Prevalence soars above 50% in incarcerated males, underscoring its forensic relevance. Substance abuse disorder, ADHD, and anxiety are common differentials, and they heighten the risk of premature death by violence or overdose. Evidence-based management relies chiefly on structured, cognitive, behavioral, and mentalization-based therapies that target impulsivity, entitlement, and victim empathy. Within correctional settings, contingency management or democratic therapeutic community programs provide clear rules and swift consequences, reinforcing pro-social behavior. Pharmacological agents such as SSRIs or mood stabilizers are reserved for co-occurring irritability or affective instability. No medication corrects core ASPD traits. Post-release, close coordination among forensic mental health teams, probation officers, and vocational services is essential to reduce recidivism and promote adaptive community reintegration. Alex was educated on anger management techniques, impulse control strategies, and empathy development. Self-monitoring of behavior, stress reduction practices, and engaging in structured daily routines was promoted to support rehabilitation. The patient is referred to a forensic psychiatry for ongoing ASPD management, cognitive behavioral therapy for impulse control, and legal counseling. Follow-up evaluation was scheduled in 4 weeks to monitor progress and risk management. When completing a full assessment, Alex states that he has no known allergies. He is currently awake, alert, and oriented, ×4. His blood pressure is 110/60, sitting in the chair, heart rate of 58, respirations 19, oral temperature 97.8 degrees Fahrenheit. He weighs 140 pounds and stands 5 feet 11 inches tall. His BMI is currently 21.5. He denies any pain at this time. Alex has denied any past medical conditions or surgeries. He denies any psychiatric family or individual history as of this day. Also, no labs or diagnostic tests were reviewed due to patient refusal. Alex proceeds to deny tobacco, alcohol, or drug use in the past or present. He states he is sexually active and lives with his parents. We see Alex as a troubled adolescent being diagnosed with conduct disorder at the early age of 14. He is faced with parental alcoholism and violence throughout his childhood, paving the way for his current state. He has never been hospitalized, had any medical conditions or prior surgeries, and does not take any medication. Alex denies fever, chills, weight loss, and pain. He remains bradycardic at baseline but denies chest pain and shortness of breath. He is awake, alert, and oriented to person, place, time, and situation, denying headaches, double vision, blurry vision, or dizziness. His respirations are 19. He denies coughing, and lung sounds are clear bilaterally. Alex denies nausea, vomiting, diarrhea, or abdominal pain. He does admit to have intermittent constipation. He denies frequency, dysuria, and incontinence. He denies any weakness in his extremities, and no wounds are noted on integumentary assessment. He admits to impulsivity, but denies suicidal ideation.
Epidemiology, incidence, and prevalence in adolescents. So, adolescents commonly acquire antisocial personality disorder, the ASPD, following conduct disorder as well when they were younger, which is needed for diagnosis. Males and poor younger had greater ASPD rates. The DMS-5 estimate 3% lifetime prevalence of the ASPD in the general population and 70% among prisoners, Fisher et al. 2024. ASPD is not diagnosed until age 18, therefore adolescents prevalence is harder to estimate. However, precursor CD is 2 to 10%, according to Fisher et al. 2024. Risk factors include childhood um, and maltreatment, home instability, and early exposure to violence or delinquent peer, Fisher et 2024. Early onset disruptive teenage are more likely to develop ASPD from prolonged antisocial behavior. Young prisoners, drug abuse, aggression, and academic failure are also more likely to have these conditions, such as Alex. By examining epidemiological trends, educators and clinicians can identify high-risk children and provide early intervention, prevention of adolescent mental health calls upon trauma-informed treatment, school-based program, and community involvement as well. Such statistical trends and risk factors can be used for mental health clinicians to develop early intervention programs to prevent childhood ASPD. So we're going to talk about pathogenesis now. Pathogenesis of antisocial personality disorder is multifactorial and begins in childhood. During adolescence, most ASPD patients develop conduct disorder, which includes chronic aggression, dishonestment, and violation of social norms. Meza et al. 2025. Antisocial behavior is shaped by childhood trauma, neglect, and family instability. According to Torov et 2023, parental breaches, inconsistency, or severe parenting, and early history of abuse influence antisocial behavior. Environment and genetic factor typical counts for problems development. Disorganized adolescents without a supportive family may internalize unhealthy behavior as means to cope and normalize disobedience and impulsiveness as well. Concealed deviant peer groups influence disregard for rules and risk-taking behavior and facilitate antisocial behavior. Schooling and stable families reduce developmental risk. CD can be diagnosed and treated prior to ASPD by comprehending its etiology. Prevention produces targeted environmental and individual risk may minimize chronic antisocial behavior and adolescence as long-term consequences as well. Now we're going to talk about the pathophysiology to the cellular level. So the pathophysiology of antisocial personality disorder is influenced by genetic and neurological factor. Genetic studies reveal 40 to 50% heritage, Shinji 2023. ASPD actively studies the warrior gene, the monoamine oxidase AMAOA gene, the abused children low activity MAOA, which regulates neurotransmitter metabolism, is linked to impulsivity and aggressiveness. Fox et at 2020. Anomalies in the prefrontal cortex and the amygdala also induce ASPD. ASPD impairs judgment and disinhibition owing to decreased prefrontal brain activity, which governs impulses, control, moral reasoning, and executive functioning, Meza et al. 2025. The underactive amygdala, which governs emotions and process fear, may explain the disorder, diminished empathy, and emotional reactivity as well. Anatomical and functional brain abnormalities impact sympathetic plasticity and neurotransmitter signaling, notable in serotonin and dopamine pathway. Chronic teenage antisocial behavior is genetic and neurodevelopmental. Understanding this underlying pattern help create better pharmacological and behavior interventions to enhance neuronal function and delay disease progression. So it's definitely important to understand the condition to the cellular level as well. So we're going to talk about neurotransmitters and the neurobiology. Neurobiological and neurotransmitters in balance have significant influence on antisocial personality disorder. ASPD impairs mood and impulse controlling serotonergic system. Research shows that decreased serotonin level cause disorder symptoms such as impulsivity and aggression. Reggie et al. 2025. ASPD adolescents with dopamine insufficiency are more risk-taking and sensational-seeking due to reward sensitivity, Shinji 2023. The stress and alertness hormone norepinephrine may also heighten emotional reactivity and aggressiveness as well. Prefrontal brain gray matter decreases, impaired judgment, empathy, and morality. Palmashuk and Williamcourt 2022. The hypoactive limbic system, particularly the amygdala, reduces unfavorable consequences, emotional impact, increasing social deviance. Disruption in the prefrontal cortex amygdala link influence emotional learning and ethical decision making. Neurobiological deficit begin early and intensify throughout brain maturation during puberty. Neurobiological discoveries explain ASPD's durability and resistance to treatment and underline to the need for early neurological screening and therapy to control emotions and impulses to avoid adult development. So this was
Clinical features of ASPD. ASPD is marked by a persistent pattern of disregard for and violation of the rights of others. As evidenced by Alex, common features include failure to conform to social norms, often leading to arrest, chronic deceitfulness, impulsivity, irritability, and aggressive behavior. These individuals frequently engage in unlawful acts that disregard the safety of others and often lack remorse for their actions. Manipulation and irresponsibility are also characteristic traits. It must be mentioned that ASPD cannot be diagnosed until an individual is 18 years of age. Similarly to Alex, an individual exhibiting similar symptoms prior to the age of 18 might be diagnosed with conduct disorder, which is widely regarded as the precursor to ASPD. Alex meets all of the criteria listed for the diagnostic of ASPD. Alex's HPI. Alex's onset stems from early childhood, with conduct disorder diagnosed at 14. Location is not applicable as it is a psychiatric issue. It has been an ongoing duration since adolescence. His characteristics include being superficially charming, articulate, explosive rage when needs are not met, a lack of empathy, rationalizing criminal behavior as a business, and having difficulty with authority. Aggravating factors include criticism, confrontation, and unmet needs. Relieving factors have not been identified. His symptoms are persistent, chronic, and the severity is high as crime is involved. Treatment recommendations. Management of ASPD is challenging as no pathway has proven to be efficient. However, one thing that clinicians do agree on is that management must be structured and requires a multidisciplinary approach. In regards to pharmacotherapy, while no medications are FDA approved specifically for ASPD, pharmacotherapy may be used to treat coexisting conditions such as irritability or aggression. Antipsychotics and SSRIs are often considered in such cases. Alex should be prescribed an initial dose of risperidone 0.5 milligrams orally, taken once a day at bedtime. 0.5 milligrams is the recommended initial dose, and we will increase incrementally by 0.5 milligrams daily until the target dose of 4 milligrams is achieved. Although the max dose is 16 milligrams, 4 milligrams has been proven to be effective without risk of adverse side effects. He should be trialed on this medication for 6 weeks with weekly follow-ups to assess labs, vitals, and behavioral response. Education would include avoidance of missing dose. If more than 2 doses are missed, Alex should contact his provider. Side effects include drowsiness, weight gain, and hypotension. Cost ranges depending on insurance, coupons, and accessibility. However, the average cost for a supply of 60 of 0.5 milligram tablets would be approximately $187.49. For non-pharmacological management, current U.S. clinical guidelines recommend cognitive behavioral therapy, CBT, as a first-line intervention and is most commonly used as it can help address impulsivity, social behavior, and emotional regulation. Alex should be enrolled in 30-minute weekly sessions for 20 weeks. If he responds well to sessions, we may increase those sessions to 1 hour. In addition, schema therapy was specifically developed for patients who were considered difficult to treat and differs from CBT by focusing on deeply rooted emotional patterns that stem from childhood. Research in a controlled clinical trial has shown that use of schema therapy had more beneficial outcomes for patients with personality disorders versus patients with personality disorders who only use standard treatment. Alex should engage in 30-minute weekly sessions for 1 year and may increase to 1 hour sessions based on his response. Education and considerations. Education and anticipatory guidance for ASPD include teaching emotional regulation strategies, empathy development, and conflict resolution techniques, which can be done via CBT as discussed above. Because Alex has limited contact with family and resides in a group home, his education should be tailored to that, and it would be beneficial if someone at the group home, such as a leader, could be a support system for Alex. Strategies for success that this leader could help enforce would be encouraging his medication compliance, which could decrease his symptoms of impulsivity and irritability. enrolling in a job readiness program which promotes him finding a socially acceptable job, which may help muster prosocial behaviors, and lastly, enrolling in anger management, as well as finding a mentor who can help him manage symptoms while giving additional sense of support. Some self-management methods include following a daily routine, which can keep Alex out of trouble and help regulate his moods. Coping strategies such as meditation or journaling when he's triggered are ways to keep him grounded. Lastly, finding a hobby that he enjoys may also be a beneficial way to blow off steam. Referrals. Alex will begin with a comprehensive evaluation by a forensic psychiatrist, with follow-up assessments conducted as needed in accordance with legal proceedings. He will also engage in ongoing therapy with a clinical psychologist specializing in CBT, schema therapy, and anger management. A licensed social worker will conduct weekly follow-ups with Alex at his group home to monitor progress, reinforce treatment goals, and coordinate services. Once legal proceedings are complete, Alex will report to his probation office for monthly check-ins to ensure compliance with court mandates and behavioral expectations. Additionally, Alex will participate in community-based peer programs on a weekly basis, offering structured mentorship and positive social engagement to support his rehabilitation and reduce recidivism risk.
Here at the end, we include our references. Thank you for listening.